good afternoon, everyone. Good to see everyone. Glad everyone can make it. Hey, good to see you. Good to see you too. All right. Well, glad everyone can make it. And today we're going to cover chronic patellar tendinopathy. Nickname for that, of course, jumper's knee, as we all know. Chronic patellar tendinopathy. So, first step, we're going to cover objectives. For this presentation, we want to know what's our objective for this presentation. So the objectives we're going to cover today are the causes of patellar tendinopathy. Another objective that we're covering is how to communicate to the patient how to properly warm up and eccentrically exercise, and also how to cool down and even ice the injured site after discomfort. The last two objectives that we're going to cover today: program length. So if you have mild tendinopathy versus acute tendinopathy, or just highly aggressive tendinopathy. And the last objective that we're going to cover today is if the patient didn't fully recover within the allotted time for the program, you're going to need to find out what went wrong, and that's the last objective. So different causes for patellar tendinopathy are going to be those abrupt stops and those quick sprints and those just quick high jumps that you hear that where it comes from, jumper's knee. Jumper's knee is patellar tendinopathy. So another reason, a little less common, is going to be metabolic reasons. So there's actually one example. Renal transplants actually show a link with destruction of tissue in general, so specifically speaking about tendons. Over time, chronic time, it just destroys slightly the tendon, so that might even be a cause. Another metabolic cause could be just that their hormones are out of balance, or chronic stress. Chronic stress releases glucocorticoids. Let me make sure I got that right. Yeah, glucocorticoids and catecholamines. Those are helpful during your fight or flight moments when you really have to have that extra boost to your heart. But stress over time and those chemicals that are released to your body aren't good for you. And they're not good for any of your tissue, including your heart. So chronic stress could be another potential reason. So program length. How long are you going to want your patient with patellar tendinopathy to be on this program? And once again, as mentioned in the objectives, depends on if they're mild or severe tendinopathy. So mild or severe tendinopathy obviously is going to extend it if it's severe, and just make it a quick, short 2-week program. Generally about 2 weeks for mild, and about 12 to 16 weeks for severe. So just a little refresher on some keywords that we're going to need to use. Some things that we're going to have to warm up and stretch, or make sure are flexible, nice, warm, and loose for the patient. We're going to want everything involved with the patellar tendon joint to be loose. So everything in the muscle tendon unit, which is the quadriceps, and everything that's in the antagonist group to be loosened. So I'm sure everyone knows what those specifics are. I'll just go over them real quick, and I have them on our PowerPoint slide: the VLO, VMO, and vastus intermedius and rectus femoris. So VLO, of course, being vastus lateralis obliquus, and VMO, vastus medialis obliquus. So we've already talked about warming up the muscle tendon unit, the quadriceps in this case, and we also have to warm up the antagonist, so the hamstrings in this case. So those I have up on the PowerPoint. You could look at those. So like the semimembranosus, semitendinosus, and biceps femoris. So the general exercise routine will be warm up, stretch, exercise, cool down, stretch, and ice the discomfort of the patellar tendon to decrease any inflammation that may have occurred. So for the warm-up, what you're going to want to do is either have a general warm-up, nothing that overloads the patellar tendon, or you can specifically warm up using a heat pack or ultrasound to warm up the specific area, the patellar tendon. After the warm up, do stretching. I recommend dynamic stretching. So after stretching, doing the eccentric specific exercise. In this case, we're going to demonstrate a slant board, single leg, eccentric. So eccentric on the way down, eccentric exercise. And so after that, we're going to want to cool down, stretch again, and ice the area in case there's inflammation and discomfort at the patellar tendon. So just going back to the specific exercise, in this case the slant board. The slant board is going to be something you're going to use. So you want it about 25 to 35 degree angle, and you're going to want your patient to stand on it on one foot and to slowly move down, so eccentrically control the squat down. And in this case, the knee can move beyond the toes. So generally squats don't move beyond the toes, but in this case it can move beyond the toes, which is going to actually increase the amount of load on the patellar tendon. So with this eccentric exercise, what we're going to want to focus on for the patient is titrating the amount and load of exercise on the patellar tendon based on pain and discomfort. Sharp pain, stop. Discomfort, you actually do want to reach a level of discomfort. You want to reach a level of discomfort anywhere between the 20th and 30th repetition, or in this case we're doing 10 repetitions, 3 sets, 30 seconds between each set. So in other words, have the patient do 10 repetitions, rest 30 seconds. 10 repetitions, rest 30 seconds, and anywhere between that point and the last set of 10 repetitions, the patient should see discomfort. If they see discomfort before that, or don't even see discomfort at all, it means you need to adjust the exercise. Either if they feel the pain too early, the discomfort too early, titrate the exercise to where it's less load, either by decreasing the amount of weight used, or decreasing the angle, or decrease the speed. If you need to progress the patient in the case that they don't feel pain at all, either add weight, a maximum of 10% of the body weight of the patient, not your own weight. And another option, you could just increase the speed of eccentric movement. So that level of pain that the patient should feel is the level of pain that they describe they feel during normal activity that discomforts them. And that should be reached between, once again, the second and third set, or 20th repetition and 30th repetition, anywhere between there. Alright, so we're almost done. We're in the second to last slide. Outcome measures. So generally, as studies have gone for this, 85 to 95% have fully recovered to partially recovered. So pretty good numbers on this one. So everything's looking pretty good. And this is all in a time period of 2 to 14 weeks, depending on severity, of course. And so outcome measures, there are no generally accepted PT, physical therapy, general outcome recommendations on how to gauge it. So, for example, some PTs could just ask as simple a question as, did it get better? Did it get worse? Is it the same? So that's the general outcome example that I would use, that I would recommend for this. So as I mentioned in the previous slide, tests have shown 85-95%, as this current slide shows. And so reasons that the patient may not have recovered, it could be they were non-compliant, they just didn't follow through with your exercise, or even they did it wrong. Another one, you could have misdiagnosed the knee. The knee's more complicated than just to say everything's a patellar tendon. So another reason could be that you didn't progress or digress the exercise correctly, or you didn't titrate the pain level correctly, or the pain was too sharp, or not enough discomfort near the end. Those are reasons that you may run into for why the patient did not fully recover. So hey, thank you everyone for being able to make it out here. Good to see everyone. See you again soon at work. See ya. All right.